All right, welcome back to Beyond Normal, brought to you by HealthSpan Chicago. As before, my name is Dr. Tyler Saunders, board certified internal medicine physician, founder of HealthSpan Chicago, a longevity focused direct primary care practice in the Chicago's North Shore. If you heard our episode 1, you'll know that the show is about what the show is about, closing the gap between standard medicine offers and what's actually possible when you have time, the tools, the relationships to go deeper. Today's conversation is a perfect example of that. Exercise is the single most evidence based longevity intervention we have. The data is pretty overwhelming, stronger than almost any drug we prescribe or any other intervention for that matter. And yet, most physicians never really prescribe it or don't really know how to create the specificity that actually moves the needle in terms of the patient's care. And most physical therapy programs aren't designed necessarily with the longevity in mind or thinking about prevention, more so acute things. And then so that gap was what today's episode's about. My guest today, Muhibb Sadiq, is a doctor of physical therapy, board certified orthopedic clinical specialist, and the founder of Element Performance and Physical Therapy. Muhibb trained at Northwestern, completed his orthopedic residency at Shirley Ryan AbilityLab, the #1 rehabilitation hospital in the country, and has built a practice around one-on-one evidence-based physical therapy designed not just to fix what's broken, but also to help people perform at their best. Muhibb, welcome to Beyond Normal.
Thank you. What a good introduction. Look at that. That's awesome. I appreciate that.
Of course, of course. I mean, you deserve it. You deserve it all for sure. I mean, one of the things when you reached out to me originally, I was saying this is conceptually really cool, and it's one of the gaps for like my clinical practice that I don't know enough about, right? And so like to be able to enhance an individual's care in a way with that expertise, I think is really awesome, and I think that's why our collaboration is gonna pay dividends for both of us and our patients, quite frankly, moving forward. So awesome.
Absolutely. And I know we're going to touch on it in a bunch, but there is so much gap between like what the information that like one primary physician might know, what a surgeon might know versus like what a therapist might know.
Yeah.
And we just need to do, all of us, including myself, like we have to do a better job of just understanding like the scope of each other's practice and who's good at what and where to go for specific things. And I know we'll get into it in a little bit, so
Yeah.
we can keep the convo going.
For sure. And like one of the things I always like to bring up with everybody too is it's not necessarily that the system itself is failing people as much as it's designed to create a certain outcome and focus on a certain thing. Sometimes that focus is on outcomes, but it's often very short term, thinking about what's kind of the next thing and kind of money focused. And we're going to be thinking a little bit more broader and seeing like, well, what's going to happen down the line that's going to actually change that. So to start off, kind of, I would like for you to talk a little bit more about like why did you build what you build? Like how did you get to the point of saying, hey, this is what needs to happen for my patients versus maybe like working with a hospital system or kind of doing a more traditional physical therapy route?
Yeah, absolutely. So, kind of like you touched on, I was doing my specialty with pretty big name hospital groups, Northwestern, Shirley Ryan AbilityLab. And while I'm in that system, in the process, like you're also looking to see, okay, what else is out there? Like, what are the potential options once you're done with the specialty? And I was like, wait a second, this is a really good program. This is top-notch program. And how are my options out there to go work as a specialized clinician? These general mills where a lot of the traditional physical therapy approach is like 2 to 3 patients in at the same time. You work with a therapist for maybe like 15, 20 minutes, 30 minutes, and then you get handed off to like a high school student or a college student or an intern, and they walk you through exercises. And so now I'm doing my specialty, and I'm like, wait a second, people's perception of physical therapy, including like surgeons, physicians, etc., people's perception is, okay, you got back pain, here's the 3 exercises you need to do. But really, there's a clinical reasoning process and framework that goes into that. One person's knee pain, one person's back pain is treated very, very differently than the same exact diagnosis, same exact condition in another person. And there's so many variables that we have to pay attention to. And so when I'm looking at the general approach, one, it was just really based on high volume. How do we get in 2 to 3 patients in at the same time? The therapist is a little bit scrambling, and now the patient's kind of left in the air with like, wait, I don't really have a timeline of recovery. I don't know what pain is safe for me to push through. I'm not fully confident on like what my condition or my potential like diagnosis is. at this point, like, do I need any kind of imaging? And so there's a lot of these questions that are left unanswered, which should be answered from day one, going to like a specialized clinician. And our job as physical therapists, and this was heavily focused on inner training, is that you have to, number one, make sure this person is even appropriate for therapy in front of you. So we do have a skill set to screen a bunch of red flags to understand, okay, is this something that's actually like mechanical in nature? Like, is it responding the way that we expect it to? Do we need any sort of x-rays, MRIs? Do we have to refer them out? Do they need blood work? Is there something else going on? That's like step one. Step two is help this patient understand in a friendly manner, like we don't want to terrify anyone, help them understand what's going on, give them a timeline of recovery, expectations of like, hey, here's a mini checklist and a roadmap of what to do and what kind of milestones you need to hit in order to keep moving forward. So that was one of the very first things I've noticed. I was like, how is this not out there? And then two, I wanted to have a space that was a lot more proactive rather than reactive. By the time people are coming in, from what I was seeing, by the time patients were coming in, they were in pain for about 6 or 8 weeks. Finally, they booked an appointment with their primary ordered potential imaging, might have prescribed some meds, maybe said like give it another 1 or 2 weeks, follow back up. At that point, like 10 weeks is gone. And that 10-week process develops so many compensatory patterns, and your brain is so important when it comes to healing, where that person now is very guarded. They're changing the way they're picking up their kids. They're skipping a bunch of workouts. Like there's a cascade of events that happen during those 10 weeks. At that point, finally, in 10 weeks, their physician might say, all right, let's try out some physical therapy. Now you've already built this like mindset in this patient where like, man, nothing's working. Okay, maybe let me just go try some physical therapy to see what can help. And that's like 10 weeks into the process. And there are studies out there that show the healthcare costs of just typical low back pain across a year. It's in the billions of dollars for this reason, where it's like people might have to take time off of work. They might have to go get extra like childcare. They might have to get extra help, the x-rays, the MRIs, the meds, the steroid, whatever it might be. A lot of that could be stopped if you walk in the first day you see a specialized therapist and they give you the appropriate guidance from there. And so that's essentially why we built the company as well.
Yeah, and it's like music to my ears because I think a lot of it is this is the same mindset and the reason that I wanted to create something myself, and thinking about what it was like being a primary care in the system. And like there's three things that you said that I wanted to double click on, and one was like thinking about the primary care sending somebody to a physical therapist. And I was actually talking to one of my really good friends a couple days ago, and he's a primary care down in Texas. And he was saying how a lot of times with things like chronic pain, for example, which end up happening because people don't address them early enough, like you said, the primary often says, well, I don't really know what to do, go see physical therapy, but that usually ends up being like way too late in the game, right? And the amount of time that's reasonable for a primary care to figure out the triage, like you were saying, like your ability to look at somebody to determine, is this the right person for therapy, is not the same as a traditional physical therapist or even a primary care for that matter. And I think that that's like a huge thing to think about, and that like being able to go and do the right timing of things. I think a lot of people talk about like professional athletes and they're like, how did they recover so quickly from this? And you're like, it's exactly what you're talking about, right? We're going to get into that a little bit more, but I think it's like, yes, how did someone recover from a torn Achilles that quickly? It's like literally within the hour, they were doing what needed to be doing to start the body's process of healing, right? The consistency and the continuity that you create is one of the other things I wanted to click on too, because it was like you were saying, we're creating a plan and a roadmap. I mean, I see some of my patients when I say, here's our next 3-month plan, and they're like, well, that's amazing. Like, that's important. And like, yeah, like that's that continuity over time, how things are going to change, I think is critical to not just physical therapy, but to kind of all medicine in general. And it's severely lacking. And I think if we had to emphasize what the gap was, right, we don't have the urgency and we don't have the consistency to create, a plan that works over time. And as we know, movement is driven on consistency, right? So,
Yeah,
and
absolutely.
yeah,
And
go ahead.
wait, I keep even bouncing off of that. Part of it's just it should never. There's there's a few things that can be wishy-washy when it comes to health, and if you're an educated professional, you can make that professional opinion where, hey, I'm not too sure how long this might take, but you're probably going to be in this realm. But even that, like at its minimum, it is also lacking oftentimes where patients are just floating in the air. Like, I don't know, is this supposed to get better at this timeline? Is it not supposed to? Like, what do we expect? From like a therapy standpoint, we tell individuals, hey, typically based on XYZ symptoms, based on your age, what's going on, here's roughly the timeline that you're looking at. Here's the little milestones and checklists that you need to meet for you to hit that. So don't get caught up on, hey, by 8 weeks, you said I was supposed to be running. It's like, yeah, but you can't do a single leg squat right now because you had a mini flare up because your knee's swollen. So like we need to make sure we hit that checklist. So like rather than getting too focused on timelines for individuals, like we have to be a lot more objective in the way we check things, the way we educate patients to help them understand like, hey, you got to be able to do 20 to 30 single leg squats. It's got to be symmetric. You can't be going all over the place. You can't have swelling if we're introducing like hopping. You've got to be able to do triple jump, limb symmetry index. Here's what it looks like, quad symmetry index. Like there has to be measures for clients to also understand. And again, that's like what we try to incorporate into everyone's programming.
Right. And if you don't measure things, you don't necessarily always know if you're improving, right? And I think a lot of people just think, well, I'm in pain, I go to physical therapy, I'm not in pain anymore. And so that's kind of one thing I wanted to bring up in this section is like, it would be an interesting argument from a patient perspective and say, well, I went to physical therapy for my back and I got better, right? And so why then do I need more specialization for something like that? So what do you think about that?
Yeah, that it's gonna be person to person. Like it's gonna be specific to each person. If someone values like, hey, I'm looking to help. Like, how do I help prevent this? You're not gonna fully prevent the recurrence of low back pain. If you have one episode in a year, I think the recurrence rate is anywhere it ranges from like 30 to 60% of a recurrence rate. Now that doesn't mean, oh great, so I'm just going to sit around and not do anything. No, if you have the opportunity to help reduce or minimize that chance, like why would you not do it? And so if someone is more of that mindset of like preventative, hey, how do I like make sure this doesn't really happen in the future? Things like back extensor endurance testing, there's a really good evidence to support if your low back extensors can hold specific positions for a duration of time, it'll minimize your risk of that happening again. Oftentimes, a lot of people, in even right now, is from the second we wake up, we're bending forward, washing our face, we're sitting, we're not doing anything to open up our spine or like to
Hmm.
extend the spine.
Yeah.
Most of our clients who are coming in with like disc-related issues, they're just lacking a lot of that extension range of motion. And so it's like, yeah, if you just incorporate some of these things 1 or 2 times per day, maybe you have a check-in once a month. You don't even need anything crazy. Just to get an idea of, okay, where's my body at this point in time? What am I feeling? Do I have any like aches or pains that are randomly coming up? Has it been more than 3 to 5 days? Okay, great, let's address it. And so if someone is valuing and it's important to them for like that longevity aspect, the preventative aspect, great. Ultimately, you're not going to force someone to do something that they're not into. And if like that's not where the priority is, then like that's okay. Our job is to help educate them on here's what I think is best for you. Here's what I'm finding. But if that person ultimately doesn't value it, then we're not going to try to force it.
Yeah. And I think that one of the things that I am trying to do with my practice in terms of education is understanding that like we're going to talk a little bit about muscle and why muscle is important. And we can also talk why injury is one of the biggest problems with that. If you look at the data over time in terms of people's lean mass, we do see a gradual decline in kind of starting in the 50s, and we see a much more steeper decline in the kind of the mid 70s. Um, and if you really look at the data, it's not really gradual at all. It's very much wise in a stepwise fashion, right? And the reason for that is predominantly because things happen, right? People get injured as one of the biggest things. And so when we're talking to patients, in our practice specifically, we're saying if we do have an issue with an injury, like we want to act on that quickly. Because as a 65, 70-year-old, if you're injured and you don't do anything to get back as quickly as possible, we're paying in lean mass, right? And we see this, and you've probably seen this in the hospital as well. We see that people that have long hospital stays, they lose significant amount of weight, predominantly in mass, because they're essentially bedbound. And unfortunately, the hospitals don't value the movement. And so they prevent patients from actually getting up because they don't want people to fall. And then we're losing more muscle mass. And so I think that like being able to be proactive about that is something that from my end is more on the education end, yours is more on the action end. But for both, like we need to tell people like if this is a potential problem and you're saying, hey, I'm not working out for 3 months because of my back pain, we're saying, are you waiting for it to go away? And like, yes, if you get some back pain when you're 18 years old, usually we just wait for it to go away and it does, right? And that's because we're 18. But when you're 65, acting on it quickly and addressing those imbalances is where we really need to, that's where we're really going to be helpful for people, and people need to understand. And so one of the reasons we even have a podcast like this is to try to educate people on that and say, like, this is an opportunity here for you to prevent worsening muscle loss over time, right?
Yeah, and I think even on that note, from a rehab standpoint too, is this is a perfect example too. Is a lot of people also think like, okay, if I'm getting, hey, my doc recommended I got to get an MRI. Hey, maybe something's torn or I have like a fracture. I can't do anything. If there is a fracture, obviously you have to immobilize that area. But the joints above and below, they I forgot what the stat is. It's either like muscle size or muscle strength. You lose anywhere from 2 to 5% from being immobilized, and it's almost per day of
Jeez.
if you're fully like in that hard cast or immobilized. And for the general person who's like listening, hey, why is that important? If you're let's say you're casted in your leg, by the time you're done, typically some people are in cast anywhere from like a week. It could be 2 weeks. We really try not to keep people in there longer than that. You're losing so much strength where now you got to play catch up. You come out of that cast, and if you're not doing anything while you're waiting for the MRI, while you're in the cast, whatever it might be, you're playing catch up to the point where now it's just going to take you even longer to bounce back up. And so what we tell people to do is like if they're waiting for an MRI or imaging, whatever it might be, we do have prehab. Like prehab is a thing where if you can beef up these muscle groups, like we have a guy who we referred him for it's a potential like labral tear and or rotator cuff tear. Can't really move around the arm. He's gonna get an MRI. He's gonna see a shoulder ortho. But in the meantime, he's like, man, I'm so stiff. I'm like afraid to move my arm. What can I do? What can I not do? He comes back in to see us. There's like a 3 week hiatus. We're able to work on like neck mobility, mid back mobility. We're gently isometric, like rotator cuff work, bicep work, tricep work, tissue work along the forearm. Literally within 1 hour, he's like, this is the best my shoulder has felt in the past like 3 4 weeks. And I'm like, even his spouse saw him, and this was over the course 2 3 week period. She's like, oh my God, what's going on? You're losing a bunch of muscle mass in that one arm. He is not even casted. He's just guarding it and protecting it. And you could
Wow.
visibly see, I
Yeah.
saw him and I was like, you lost a lot of muscle mass. He's like, yeah, I'm not really using it. I'm too afraid to use it. By the end of the session, we were able to walk him through like, hey, you can add in bicep curls, tricep extensions, some mid-back workouts. Even if you do have to get a surgery, these are the muscle groups that are going to get hit. And so if your strength right now is like 60%, after that surgery, I'm making this up, you might drop to like 30%. What
Sure.
if we beef you up to like 80%? After that surgery, you're only going to drop to maybe like 40, 50%. So you're going to be in a better boat. So a lot of
Yeah.
people think even if they're immobilized or if they're waiting for imaging, et cetera, like you can't do anything. No, we want to work the joints around it. There's safe ways to do it in a rehab setting, like blood flow restriction therapy is phenomenal, and maybe we'll go into it later. But
Sure.
for individuals that are either in like an acute flare-up where, oh my God, I can't handle this, or in this instance where this individual can't really handle loads, it's a phenomenal way. It reduces the amount of blood flow that goes to the limb. You could do a very basic body weight movement or very, very light resistance, and there's a certain set rep parameter that you do it at, and it makes your limb feel like you're pushing like 100 pounds. And so it triggers those same strengthening effects as if you were actually lifting heavy without irritating any of the structures around that joint.
Yeah, that's cool. The prehab concept, I think, is something that's really interesting. I've had a lot of conversations with physical therapists. At my previous job, there were a couple of physical therapists that I think really kind of understood the value of strength and maintaining strength. And we used to have conversations about, I used to ask them, and I know there's some PTs that advocate for this before, is like, does it make sense to do like a once annual prehab screen for physical therapy to potentially identify injuries? Now, we're starting to get into the question of like, how expensive is that going to be, and all this stuff. But at the same time, like, we're getting into an age here with medicine where the medical system, it has a specific role, and it's not in prevention as much as it should be. And that's why we've created the practices we have to think about that a little bit. And it's like, does it make sense to figure out a time or a place to say, here's imbalances that may set us up for injury, and thinking about how can we build a plan around decreasing it. So I mean, I love the prehab concept, but it goes back to the same thing you were saying before, and a lot of people still have the mindset like, well, if it isn't broken, why am I trying to spend extra time and money to do stuff? But I think once you get injured and you don't recover as nearly as fast as you used to because you're just older, then you start kind of thinking about this like, the name of the game here is prevention, right? I always tell my patients, kind of jokingly, injuring yourself is unacceptable, right? Now, I've injured myself, and it happens, and there's only so much you can do, but setting yourself up for success by thinking about those things ahead of time, I think is like a really good way to think about it. So
Yeah.
let's. Oh, you have something to add?
No. Keep going.
Cool. Yeah. So I wanted to kind of move on a little bit so we make sure we cover everything we wanted to in the time. We want to talk a little bit about the evidence around movement. Now it's like, as you mentioned before we started recording, like we could probably talk about this for a couple hours in itself. One of the things we do in practice is we test VO2 max testing because it's a strong predictor of all-cause mortality, even stronger than things like smoking, diabetes, heart disease, and things of that nature, as well as body composition testing. So I kind of wanted to get a little bit of your perspective on, the evidence related to the cardiorespiratory fitness piece as well as the muscle piece and how important it is to performance and rehab.
Yeah, absolutely. And there's so many ways and there's so many directions to dive in with this. I'll start with older adults primarily, so that all of us ultimately we're aging. There's no way to avoid that. There's very basic tests that we can do from a rehab setting to see if someone's at a fall risk for this individual. Very basic test is like a 5-time sit to stand, where you're sitting on a chair, you stand up, sit down, just 5 times. You want to aim for less than 12 seconds, and that decreases. It's a good indicator. It's a decreased risk for falls. There's other tests like Berg balance, time up and go. There's different other measures. The whole point of these performance measures is just that they are performance measures. The people who perform poorly on them are typically going to be the individuals that are a little bit more on the frail side, sedentary side. They don't have a lot of muscle mass. They don't have a good history of working out, exercising. The ones who tend to fall are these same people. The ones who tend to fall have these hip issues, stays at a hospital. Then now you're talking about potential like complicated fractures, doing a hip replacement, do we need a consult, It stems from people that aren't living this active lifestyle, that aren't building muscle, etc. The job of your muscles, all of your muscles in your body, is to help absorb impact, period. The more, anytime you look at runners, if you look at some of these like not cross country, some of these like power athletes, they are very dense individuals because they have to pull so much weight. It's got to help with shock absorption. If you take a very dense individual and they have a fall, chances are like that same fall, their bone quality or their bone health is going to be a lot denser than someone who's probably not engaging in that kind of activity. And so I start from that standpoint purely to help people understand, like, listen, as we get older, that's unfortunately like a reality where we are going to lose muscle mass per year. I think it starts from the age of like 30, 32, something like that, where it's like a 1 or I don't remember the exact number, but it's between like 0 to 2% of a muscle mass per year if you're not doing like strength training. And that is like the baseline, where if you're looking at that, let's try to act preemptively beyond that. And so even in our athletes, or not even athletes, our recreational athletes, people are coming in and just want to be active. We're taking a look at movements like single leg squatting patterns. We want to aim for a certain rep amount. Triple jump, we're looking at that. We have like a force gauge where we can actually measure like quad strength, hamstring strength. For certain knee injuries or conditions, we really want to make sure we're within a specific percentage, like 0.6 to 1, a hamstring strength to your quad strength. And so there are measures that we look at. Really, really good evidence coming out, even to this day, about hand grip strength and mortality. I forgot the exact numbers, but if you're missing, for every like 10 pounds roughly of grip strength that you're missing, it increases mortality risk by like close to 20%. And it does plateau at a certain point. But all this stuff is literally just to go back to the same concept of we need muscle mass, period. You need strength training, especially as you get older, because the natural process is you're going to lose muscle.
Yeah. Yeah. I mean, it's like, I wish I could just like sit my patients down, right? And just, you could tell them that every time. I might just record it and give it to them. No, no, but I mean, seriously, like, the importance of it is like overwhelming. One of the couple of things you said I wanted to double click on, one was the absorbing impact. I have a couple of patients right now. I think it would be very helpful for them to hear it coming from you as well, where we're talking about the structure of their foot and we're talking about the impact absorption of the foot. And we've been trying to do a couple of exercises and things, and we're creating a lot of pain in the foot because we're not absorbing anything. And essentially, for a lot of the people in the audience, they might not know what something like a Charcot foot is, but essentially what it is in the setting of diabetes, you can't feel your foot, so essentially your foot just smashes on the ground. You don't have that absorption piece where it's taking in the impact, and then the foot over time just slowly starts to break down, essentially. And so a lot of people's feet just get jammed in shoes or orthotics. They're not spreading out, they're not using the muscles, and as a result of that, they're not absorbing any of that, the impact, right? I think it's when you're running, it's like 6 to 8 times your body weight on each leg every time you step, right? And so if you're not absorbing that impact, the bone is just taking the heat, and not in a good way, right? And then that affects the structure. If you think about like a good arch on a foot, like part of that, at least theoretically, is to absorb the impact, right? And not stay stiff. And what we've done oftentimes is put people in really stiff shoes and just jam them in there, and we're not using the ability of the muscles to do that. So then the answer becomes we need to develop that muscle in order to improve the absorption, right? And that's going to be critical. So hopefully I'm explaining that right from my perspective. I don't know if you have any thoughts on that, but I
Yeah,
wanted to
absolutely.
reiterate it for sure.
Yeah, no, like literally two things also that you touched on that I want to touch on. So even when it comes to the arch of the foot, you're actually at a higher risk of injury if you have really rigid and really supinated or like a high arched foot.
Yeah.
And people are like, oh my God, I thought having like a good arch is helpful.
Yeah.
You need a quote unquote a good arch is one that's like movable and it's like pliable. So even
Yeah.
when we move people's feet, if there's a bunch of stiffness there, like you said, that shock absorption
Yeah.
component is big. But it's also like just yesterday, we're working with someone who's coming in with knee pain. His main issue right now in his last phase of recovery is shock absorption. And when we explain that to clients, they're like, well, what does that mean? It's like, well, the ability to, you could train your muscle in certain, train your body to maximize certain positions that help to reduce the amount of strain that goes everywhere. What does that mean? If you're jumping and landing, there's a specific like hip hinge pattern
Yeah.
that you can utilize to put a lot more of the weight in your butt so that it doesn't go to your low back, so it doesn't really go to your knees, so it doesn't really go to your ankles. There's specific foot positioning, knee positionings that we can utilize during specific workouts that help to reduce the amount of impact that go everywhere. And those start to train these bigger muscle groups, your glutes and your quads, which touches on to that second thing I wanted to mention when we talk about shock absorption. People who come in, anyone who has knee arthritis or anyone who's been even told, let's say they got imaging, oh my God, I have knee pain, doc said it's potentially arthritis. There is such strong evidence out there for quad strengthening in the reduction of knee pain related to OA. And why is that important? Your quads job, your glutes job, it's primarily to help reduce the amount of impact every single time you walk. And so if you see some people, for anyone who's listening, like if you see people walking out there and it almost looks like it's almost like a peg leg where it's like fully locked out and they're kind of
Yeah.
like going side to side.
Yeah.
That is a very rigid walking compensatory strategy where if someone's missing a lot of that quad strength or glute strength, naturally it is easier to lock out the leg and kind of just hobble onto that leg.
Yeah.
And so even when we talk about shock absorption, for people who think, oh my God, knee arthritis, I can't do anything about it, blood flow restriction therapy is huge. The amount of times I get older adults who come in and they're like, like even just getting out of this chair is uncomfortable, like walking's uncomfortable. We put on that blood flow restriction therapy cuff, the BFR cuff. We put it in that 60 to 80% range of their max occlusion. We just have them do some basic straight leg raises in like a specific parameter. Literally instantly they stand up, they're like, oh my God, this is the best my knee has felt. And so yeah, that person who's about to get that knee replacement, imagine how much when you get a knee replacement, your quad gets hit so badly where that's one of the main things that you got to work on, that quad strength and that quad atrophy. If you can beef up your quads with blood flow restriction therapy leading into that, it'll help your shock absorption. You'll feel better going into your surgery. There'll be less swelling. It might make your outcome better.
Yeah. Yeah. I mean, when we talk about the prevalence, I guess, of surgeries, I mean, how often we're doing surgeries for knees, hips, and things without probably the proper, physical therapy evaluation and or just program to allow them to make improvements. I got to imagine it happens pretty often, or just the ability to prevent someone from having surgery sooner than. And so I have one kind of personal example as it relates to feet, in that I ended up having an issue with one of my toes in residency. Went to PT, saw a bunch of people, went to podiatry, went to orthopedic, And then I got to the end where they were like, well, I guess we have to do surgery because I had had some stress reactions and arthritic changes in one of my toes. And I'm like, in my 30s getting arthritis. I'm like, what's going on here? I'm like, this is very clear to me that there's something wrong with the mechanics, right? But that wasn't really something that was brought up to me. It was more so me just kind of like hitting my head against the wall, trying to figure out like what I need to do. The right thing to do would have been to find someone like you, had I known you at the time. But so what I ended up doing was a lot of like, we need to strengthen, we need to improve absorption, we need to improve. I have very flat feet, which I was always told was bad. The reality of it is it's not necessarily bad if you're kind of doing the right things. I've been able to strengthen my feet a lot and it's not really an issue anymore. And I'm not an expert in this by any means, but I needed to kind of go off on my own to explore this. And what we're telling patients here is you don't have to do that. And if I was in a position where I even knew like what you're doing existed, I could have hopped in when I was probably in my mid 20s and avoided the problem altogether by figuring out how we're transmitting forces and how I'm absorbing things, and that I beat my feet up pretty good running by throwing them in shoes with orthotics and wasn't engaging my feet at all, right? And so the reason I bring up this story is because I was proposed surgery, and people get proposed surgery all the time, hips, knees, etc. And as you were saying, you can do certain things that will strengthen. Just strengthening the quad is something that maybe they don't need surgery, or maybe we can push surgery off a couple of years, right? I mean, some of the changes people need surgery for is because there's no cartilage anymore and there's just only so much you can do from strengthening. But there's always like think something that you can do, and it needs to be more personalized. I mean, we're gonna beat that concept over the head, but it needs to be, because as you mentioned at the beginning, two of the same diagnoses can have very different plans based on an individual's mechanics. And if you don't have somebody who knows what they're looking for looking at you, that might be missed, right? And you're going to do kind of more of the generic algorithmic type exercises.
Yeah, and I mean, even again, just piggybacking off of that, like everyone, or not everyone, not to say that surgery is bad at all.
Yeah.
There's a time and place for
Right.
it. In
Yep.
a personal example in my practice, it's not like, oh my God, every single person, we're not recommending surgery. Personal example, we've been working with this client who's coming in with knee arthritis for a while. We're on like a maintenance type of plan where every week symptoms are going to be different. One day it might be a flare up. If it happens to be really rainy out there, her knees are going to be really uncomfortable. We're going to do a lot more BFR that day. If a day is feeling pretty good, great. We're going to load her up on like a belted squat, leg press, quad extension, etc. At a certain point, within about like 12 to 14 weeks, we're still seeing improvements, strengths improving, day-to-day functions improving. At a certain point, we start to see a plateau. And that's when we have that conversation with this client of like, hey, listen, like from a day-to-day standpoint, if you're okay with these type of symptoms, this is probably going to be like the peak or the max that we kind of hit based on how long we've been going at it for. But at the same time, if you're like, no, I'm really tired of this and I just want to get that knee replacement, I'm
Yeah.
happy to support you for that. I
Sure.
think you're going to be in a good position for that. And so, yeah, this person will be getting a knee replacement. Most likely, she will be replacing that second knee because at a certain point, she's like, listen, I'm tired of damage control.
Yeah.
Absolutely. I would be
Sure.
tired of that too. I am comfortable knowing that we've exhausted, explored, and have loaded you up to this point to understand that rather than jumping into this about a year ago when a lot of her
Right.
strength was not there, period.
Yeah. Right. It's like the preparing for surgery. I think not necessarily just from a strength standpoint. I also think about this from a pain standpoint too. We know after a knee surgery specifically, there's certain pain associated with it, and one of the things is making sure we maintain range of motion, right? And so a big part of that is on your end, but also the pain management standpoint. And that I've had a patient in the past who refused to take certain pain medications, and I think for a reasonable reason, but she ended up getting significant restrictions post knee surgery because, and now she doesn't have the range of motion. And so, what do you think's happening down the road? We're having knee problems, we're having other issues because we're losing that range of motion. When in reality, I wanted to ask you this question anyway. I was going to do it a little bit later, but we can do it now. Is when we think about aging, we think about the loss of muscle mass. We've mentioned it a couple times. The other thing we think about is range of motion loss. Do we need to lose range of motion as we age?
I think it depends. So there's like certain, we have clinical practice guidelines
Mm-hmm.
and they're specific conditions. And for everyone listening, these guidelines are like they look at all the evidence out there for specific conditions, for certain ailments, and they rank them based on like levels of evidence, and they compile it just to make certain conditions easier to understand and digest, and to help maximize recovery. And so certain things are associated with a lack of that range of motion, but that doesn't always mean that that lack of range of motion will lead to that. Now, that being said, if we do have a client who comes in with neck pain, like one of the guidelines that we look at is if you have less than like 65 degrees of rotation side to side, plus a couple other positive tests, and you're coming in with like these radicular symptoms, that fits a cluster of like a cervical radiculopathy.
Sure.
And so we can sometimes like pull out some bits of that information where someone's like, hey, my neck's been getting really, really tight, and you look at the range of motion, you're like, you're stuck. Well, ideally, let's bump you up to above 65 degrees, especially if you're above that on the other side, to help restore that. From a knee standpoint, like longevity range of motion, we ideally want you to be symmetric side to side. But the minimum is like 0 degrees, meaning you should be able to fully lock out your joint. What happens if you can't? Literally 1 degree of that difference. You can't detect it with the eye. You're like, there's a couple of tests that we do for that.
Sure.
But 1 degree of that loss of knee extension range of motion changes the way your quad functions. It changes the way the impact goes to the knee joint, and it can alter your mechanics.
Jeez.
And so that doesn't mean that, hey, everyone who's lacking that range of motion will go and develop that.
Yeah.
But if we kind of know some of these are indicators of certain conditions, it's like, hey, what happens if we try to get ahead of it?
Right. Yeah. I mean, we all see this, and we see it in our people we know. We see it in patients, and we see there's a certain type of, I don't know, it's like I could say phenotype, something you see. You see a patient who physically looks a certain way, and as we age, we tend to see kind of the arch in the back, the lean forward, the inability to really stride out. I was at the Botanic Gardens yesterday, and one of the guys that was helping like volunteer, he was going to show me something. He started walking in this like very low shuffle gait, very little. You could tell there's very. I'm not an expert in range of motion by any means, but you can tell there's significant restrictions, And my point of the question originally was like, those don't need to be there, but they've been created and they continue to compound and worsen themselves over time, right? I do manipulation in practice, and I see these range of motion restrictions, right? I had a patient I was seeing for a couple of years who really couldn't really go more than like 10, 15 degrees side to side, and it was a compounding thing. It was the range of motion was bad, it caused pain, the pain caused range of motion to get worse and worse and worse, and now to the point where it needs to be like a full body rotation, right? And I don't think that was I think a lot of that was to a certain extent preventable, maybe not all of it, but I think if it's identified and put through a specific plan, I think it would be something that could be changed.
Yeah, the perfect thing is literally, if you don't use it, you lose it.
Yeah.
And that applies to everything. Think of for I don't know the majority age range of the audience, but anyone, I'm 32. If I even go shoot, I used to play I grew up playing basketball all the time, twice a day, whatever it was. Now that I have kids, I barely go. If I take them to the park, I'll get a few shots in. Even the 20, 30 shots that I throw, the next day I wake up, I'm like, man, my arm is sore.
Yeah.
I'm working out, I'm doing military press, overhead pressing, etc. But if you don't use that specific movement pattern, those muscles are not used to it, and you end up losing it. Yeah. Same exact thing with your mobility. If you're not exposing your spine to specific directions, you're not maximizing your usage throughout the day, or you're not even just like exploring some of these movements, you are going to lose it. Even for hip OA, there's like, based on the ACR guidelines, like clinical radiology, specific ranges of motion loss when we're assessing it is coupled with like knee arthritis. And it's like, well, someone might be like, I used to have this range of motion and I don't know what happened and it went away. If you think about our hips, everything is like we go up the stairs, we sit down, we get in and out of a car. We're only exploring like 20 to 30% of what's there.
Right.
If we're not doing anything to explore the rest of it, your body's like, hey, I don't really need this. I'm going to be a little bit more efficient. Let's just tighten up over here because like we don't need it. Right. And so, that's where it becomes important sometimes to get ahead of some of these things.
Well, that's like, I bring up the question of like, is this aging or is this not using it, right? Because you see people 70s, 80s, 90s playing tennis, doing this, still running and things of that nature. And you're like, then you see other people and you're like, there's no way they would even be able to get remotely close to that. And is it because they aged better, or is it because they just didn't stop and they continued to do those things, and the body can continue to do because the body can adapt to the things that you do, right? And so I think that's always the question. I think people come in, and a lot of, I think, clinicians say these things like, well, this is because of aging. I won't tell a patient this because I don't know that for sure. And I also believe that the body is capable of doing a lot of things, even though we are definitely going way beyond what evolution had in mind for our overall body. I think that we have the ability to do a lot of things. But like you said, we have to either keep doing them, or if we stop doing them, we have to have some structure that's going to bring us back, because we can't go from not doing anything for 20 years and go hurt ourselves playing pickleball, because we see that plenty, right? Because in here you can still do it, but physically it's not quite the same thing.
It's not there. Yeah, I have a client in their I have a client in her 60s who's still doing like half marathons, and we're helping
Yeah,
her prep for it.
right.
And I was like, "Oh, nice. Are any of your friends doing this with you?" And she goes, she laughs right away. She's like, "No, none of my friends. Even the thought of running, they're like, no, my knees can't handle it, my back can't handle it, my hips can't handle it." And she even said this to me. She was like, like a part of me sometimes wonder, is it just because you didn't do it for so long, and now there's so many issues going on where, yeah, it is uncomfortable to go do it, or is it truly like your body's way to like it just kind of went that way?
Yeah.
I'm a firm believer in, like, obviously you can't control aging, but if you've been resistance training, working on your aerobic capacity, you've been staying active, and then it happens, great. You've tried to do everything you needed to do, and like God just had a different plan for your
Sure.
body.
Hmm.
But if you haven't even explored that,
Yeah.
you haven't even uncovered, like, you're missing like 90%
Yeah.
of the puzzle right there.
Yeah, I mean, and the concept of all these people saying, "Well, my knees would hurt," you're like, this is, we go back to the absorption impact problem again, right? You're saying, well, you've lost a lot of the muscles that you didn't use that would engage in the ground, so to speak, to absorb it, and therefore you don't have it. And so when we talk about taking your bone with its nerves and smashing it into the ground, the body doesn't like that, right? Because it's not necessarily at that point, it's like it's not prepared for that stimulus, and so you have to make it so it can be. And I think one of the things with aging that we have not figured out, a lot of people in the longevity community are saying, oh, we want to live to 120, 130, 150, plus. We still haven't solved for the sarcopenia problem, the problem that we do lose muscle regardless of what we do, right? We don't see a lot of 90-year-olds busting out of their shirts and muscles, right? And so the reason for that is because we don't know what to do with that problem other than physically using the muscles. But even in that context, you're going to lose some muscle mass, right? And so, and that's okay, because it is what it is type of thing, right? And so that's the part I don't think we're going to be able to necessarily fight, despite the fact that there are a lot of people doing research on drugs to prevent muscle loss. We'll push that to the side for now. But the idea is, like, we need to be able to continue to think about, what do we need our muscle for? What do we need our health for? And this is the kind of the concept of my practice itself. We use the word health span. What do we need that for in 20, 30 years down the line, right? Or however long you're going to live, because if we're doing the things now, we're increasing the likelihood of being able to do the things we want to do, right? This is why we do VO2 max in our practice. It's because I can take your VO2 max today and forecast where it's going to be 10, 20, 30 years down the line. And if one of your goals is to be able to travel, or you have to be able to, like, go upstairs, go up a hill and things of that nature, and your VO2 max will predictably decline with age, as we know, then you're not going to be able to do those things, right? And that should change your perspective on how you think about this. What are we doing in prevention of preventing it from getting to that point where now you have to predominantly just sit and walk around and not do a lot? And a lot of people fall into this trap where it just happens slow enough that you don't see it. And then the next thing you know is you're not able to do certain things. And then you're like, oh no, what happened? Right. And so from the longevity perspective, I think that that's like a huge thing, and that we like to think about in practice. But being able to try to put it and actually have people do it, this is the hard part, right? And we're trying to make it as easy as possible for people to think about that. So the planning, what's the next step? How do we move into this space, right? Because it's hard to see and visualize, and it's hard to think about like, when I retire when I'm 65, what do I need to be able to do, and what do I need to do now in order to get to that point?
Yeah. I mean, we tell people at a bare minimum as they're getting older, because we have clients who come in for like maintenance kind of work, or they just want to do little check-ins. And like 2 days a week, if 2 days a week, regardless of what your goals are, if you're an adult, 2 days a week, you should be doing some sort of like jumping, hopping, or like running. Because
Yeah.
the amount of times also that like, imagine like you're at a kid's soccer. This actually happened. One of our clients, maybe a year or two ago, she was like, yeah, I was at a kid's soccer game. Everyone decided, oh, let's just like all the parents, let's just go play with them or whatever. One of them stepped on the field, tore the meniscus, just within like a little, just within like a jog or like a
Jeez.
hop. And I'd asked him, like, hey, just curious, like when was the last time you had like jogged or hopped? I don't. The
Don't
person
know.
was,
Yeah.
I don't know. And that's the thing. Like if you're not, if your day to day function is like 20% of your body's capacity, and you spike into 100% activity, even if it seems like it's light, it's gonna feel like a huge spike for your body.
Yeah.
So we tell people bare minimum, even for like plyos in general, plyos like jumping, hopping, anything bouncy, just do it like 2 days a week.
Yeah.
It doesn't take much time.
Right.
2 days a week, incorporate that, and then obviously like 3 to 5 days if possible, the strength training with some like cardio work in there as well. But the if I tell people, I'm like, if people could stay bouncy, people could stay like jumping, hopping twice a week as the years go by, they're going to significantly reduce the amount of potential problems that happen. You don't
Yeah.
have anyone who's falling, breaking something that's like
Yeah.
someone who's jumping, hopping around. You don't have someone who's um, the grandma, grandpa who's running around after the kids. This
Yeah.
person can hop around, it can jump around. The person who's like stands up and is uncomfortable when you get out of the chair, they're probably not going to be able to be doing that.
Right.
So we try to encourage and emphasize and reinforce, like just 2 days a week, do something that keeps you like bouncy.
Yeah. Yeah. I mean, I think you bring up a good point in that, like, the personalization of medicine that we're talking about and we're doing clinically isn't necessarily always available to everybody from a financial standpoint, and that's okay. But also, like, some of these small, nuggets of information are super helpful, that are like, hey, this is something that is very simple, something that you can do, something that you can build up to. And the reality of it is, we talk about our longevity, our quality of life over time. It doesn't need to be the latest and greatest, fanciest thing, right? It doesn't need to be these things. I mean, we're not going to talk about this in depth, but like, there's a lot of craze going over like medications and peptides to heal faster, right? And so, is that something you need because it's new, fancy, and shiny, versus like the fundamentals, right? Which in an injury perspective is acting quickly, thinking about the way you're preventing injury. If you do get injured, then trying to set your body up to prevent it from happening again. And maybe it's something small, like you were saying, hopping, being more bouncy. Maybe it's just maintaining the muscle mass and these things. And that these the fundamental ideas, and the reason that one of the main reasons I built the clinic is that this basic lifestyle things are actually not that difficult, and we don't need to get lost in the clouds with all of this other fancy information, right? And so, that's something I just like to emphasize, because yeah, there's a lot of little things we can do, and a lot of the biggest successes we have clinically are like, well, this person consistently did some exercise versus none for 6 months, and it made a huge difference, right? Or this person changed the diet in a way that improved things. And so it's like, I think kind of small little things like that really pay huge dividends, especially if you're coming from like that zero where you're not doing much of anything, right?
Yeah, and I think sometimes the best answer for people, like simplicity, is sometimes the best answer for people.
Yeah.
And what I
Yeah.
mean by that, we had a client coming in, had knee pain, years in his 60s, still plays tennis, and pain does not equal damage. So for everyone listening, just because a joint area has pain, that doesn't mean you're damaging it. There's certain
Mhm.
guidelines that we can walk you through
Yeah.
to help you understand like what's safe to push through, and it's actually helpful for healing. But literally took a look at everything, and the fancy term for it, with patellofemoral pain syndrome, essentially it's just a lot of impact of his kneecap along that area. We do a handful of quad stretching. I'm not even joking. 30 seconds, 2 to 3 sets of it. He rechecks his squat. He's like, wow, my pain
Yeah.
feels so much better.
Right.
If you just spent 30 seconds a minute doing that quad stretch, leading pre-tennis, during tennis, when you
Yeah.
get like cold, and we walk people through like a proper warm up. If it cools down, here's how to do a proper cool down, etc.
Right.
But my point with that is, he was also shocked that how does this simple stretch that I see all the time give me so much benefit. And well, one, when you know where the pain's coming from, you can treat it pretty
Yep.
well and pretty
Yeah.
quickly. But the other one is going to be a volume. I'm like, hey, how often are you doing this? How often did you try this quad stretch? I
Yep.
maybe did like once a day. There
Sure.
are 24 hours in the day. If you spend 30 seconds stretching,
Yeah.
23 hours and 59 minutes is going to undo everything. I can
Yeah.
promise you that. And so
Right.
for a lot of these mobility things, we tell people every 1 or 2 hours, just spend 20 to 30 seconds.
Right.
For desk workers, if you're sitting every
Yeah.
like 10, 15 minutes, just stand up, do a bunch of back stretches. Every hour or two, do some back extensions. For people that are on their feet all day, we'll literally tell them, hey, can you stand? Can you like grab a ball and just like smash the bottom of your feet? Because everything
Yeah.
gets really, really stiff or tight.
Right.
And so sometimes simplicity is the best answer for people.
Absolutely. And I think sometimes the value of, like talking to someone like you and understanding that doesn't mean they need to come and see you every week indefinitely. It means like you can give them a lot of very like small things and say like, if we can do this consistently in this small amount of time, like we're going to see big change. And if we do that before injury, we're going to be a lot more likely to be successful and less likely to injure ourselves and things. So I want to be really conscious of your time. I know we're kind of running out of time. I wanted to cover one more thing before we wrap up, and that's what happens when a physician and physical therapist work together, right? This is something that we unfortunately don't see as much as we'd like. I will be honest with you. In my previous position, I told my patients, here's a list of physical therapists I like. I want to make sure you're one-on-one. And then that's about it. Now, the physical therapist would send me a plan, and that was amongst another like 80 things that I had to do for that day. And I would briefly look over it and say, looks good, right? And so, from our perspective and kind of where we're hoping to kind of move our relationship is saying, like, what happens when we communicate and how much does that help a patient work towards their goal, not just from a physical standpoint, but also just long-term health?
Yeah, I think this is a perfect recap because even right when we started the conversation, we talked about potential, like almost $1 billion cost of low back pain. We also talked about when you get when the traditional system you get injured, people typically wait 4 to 6 weeks. They'll try to rest ice. Maybe they'll go see their physician, and hopefully that physician has an opening within that week or two. So
Yeah, well, yeah,
you might be at like 8 weeks before you go get a check. Might
yeah,
order an X-ray. Might tell you to wait. Give you some meds. At that point in time, about like 10 to 12 weeks before you see a therapist.
yeah,
Whereas, and by then you have all these compensatory patterns that kicked in.
right,
Versus, go see that physician. Hey, by the way, I've been having this like random ache or pain that's been coming up.
yeah,
It has been impacting my day-to-day function,
right,
and like I'm not sure what it is. Day two or within that week, great. Go see this group of physical therapists. They can help you figure out what's going on.
yeah,
Within that week, a couple of things happen. You do that eval, and we help people understand where the pain's coming from, why it's happening, what's safe to push through, what to back off of.
yeah,
Do you need any X-rays? Do you need MRIs, or
right,
like save your money for that?
yeah,
Is there something else going on where hey, this is not a pattern? Like you might need blood work.
yeah,
And we help people understand like a roadmap. Here's what it
yeah,
should look like by week 2, by week
yeah,
4, by week 6. If your goal is like this more active goal by week 12, here's where you should be at.
right,
And within that 1 week now, you've squashed so many compensatory patterns. You've helped this person understand what is safe in their day-to-day life to do. You've saved an insurance company and the patient and the physician from prescribing meds potentially. You saved them from imaging if it wasn't necessary. And so even these insurance companies should see it as an opportunity to cut costs. All these
yeah,
insurance companies are looking to cut costs.
yeah,
The problem is you wait for this huge flood to kick in before you decide to act. Whereas when there's a little drip, why don't you start to address that drip before it becomes something big?
yeah, absolutely. Yeah. I mean, I will kind of end with one little thing, just piggybacking off of that. I mean, we know in medicine, if you look across what is some of the most effective strategies to help patients, is multidisciplinary approaches, right? And so my expertise, your expertise, someone else's expertise, like if you have multiple people looking at the same person in a different light, I'll use heart failure clinics as an example. It's very known in the literature that these patients do better in a heart failure clinic than they do in just seeing a cardiologist by themselves. And it's not to the cardiologist's fault. It's just that when you have these different pieces all together, you're getting different perspectives. You're kind of creating a plan together. And so for my vision for HealthSpan Chicago, is part of that is to have that network of people that will communicate with me about what's happening on their end from their expertise, what we're working on, and then trying to put that all together for a very specific plan for that person.
Yeah, I think right now there's too much of a oh, I don't want to go see this provider. I don't want to see this provider. Like everyone is their own like column essentially where, oh my God, surgeon, uh-oh. Where it should really be like that circle, like that interdisciplinary approach where no, there is a time to go see your primary. Absolutely, you absolutely need it. There is a time to go see that surgeon. Like at a certain point, you absolutely need it. There is a time for that physical therapist to be there. And the sooner we can try to understand what everyone does and where everyone's expertises are. Like for us, we don't do pelvic floor work, like pelvic care. So someone who just had a baby, I'm going to go refer them to a therapist who does pelvic floor therapy. And so the more we understand what each provider does, what each scope of practice entails, the better and the quicker patients can get better, and the better their long-term outcomes can be.
Yeah, absolutely. Before I come in with the outro, is there anything you wanted to say? Anything before we finish up?
No, this was awesome. I could literally talk to you all day about this stuff.
Sounds good. Well, maybe we'll have you back. We'll do a little bit more. I think we just tip of the iceberg with a lot of this stuff anyway. But so yeah, let's kind of go in with the outro. Thanks for being here. This is kind of conversation I was hoping for Beyond Normal. I wanted to kind of create this idea of people thinking differently, becoming more educated about what they can do, what's possible. If you'd like to learn a little bit more about Muhibb's work, you can find Element Performance and Physical Therapy at elementphysicaltherapy.com. And I can post some of this with the video if anyone's interested. And if anything we talked about today resonated with you, or you ever felt like your health deserved a little more attention from that the system's not quite giving you, I'd love to have a conversation with you. I'm sure Muhibb would as well. HealthSpan Chicago is we're currently accepting patients. You can kind of do a free discovery call if you'd like through healthspanchicago.com. Before we go, quick note: everything we've discussed today is for educational, informational purposes only, and does not constitute medical advice. And listening to this episode does not create a physician-patient relationship between you, me, or either of our practices, or anybody else that's mentioned during the show. Everyone's health is different. Please work with your own physician and healthcare providers before making any specific changes. And we'll see you next time on Beyond Normal.